But welcome, everybody. It is such a pleasure to chair this wonderful webinar today on the interface between physical and mental health in children and young people. And we have two talks for you, the first by Professor Sarah Garfinkel, and then a talk by Dr. Sophie Bennett. And Sarah's going to start, and Sarah is a professor of cognitive neuroscience. And in the couple of minutes, while you were all waiting to come in and we were getting started, I asked Sarah how she'd like to be introduced. And Sarah said that she finds long, lavish introductions slightly embarrassing. So I won't give you a long, lavish introduction, Sarah, but just to say that your work is really outstanding and incredibly original and just really applicable both to clinical work and to basic science. And you really cross so many different interfaces, and it's a real pleasure to welcome you and really excited to hear your talk today. So I'll hand over to you.
Thank you so much, Roz. It's a real pleasure to be here. So today I'm going to talk to you about the interactions between mental and physical health. So there's a high co-occurrence of mental and physical conditions, and this can operate through many different pathways. So, for example, different physical conditions can lead people isolated, and this can contribute to deteriorating mental health. Mental health conditions may be the origin, and through different stress pathways or, for example, sleep disturbance or changes in behavior, such as drug taking and other different behaviors with food intake, this can lead to a consequence for physical conditions. But also, and this is the one that I find to be really exciting from a physiological perspective, because it has deep implications also for the ways that we might be able to treat different conditions. There may be a shared etiology between physical conditions and mental conditions, such that they may have underlying and overlapping pathway in brain and body, which might contribute to the manifestation of them both. So the brain and the body are intrinsically and dynamically coupled, and mental health is entwined with bodily systems. And a lot of my research looks at these body-based origins of different mental health disturbances. And we can see this high co-occurrence of mental and physical conditions. And then for the talk today, I really want to focus on three different conditions. I want to talk about schizophrenia. I'm also going to talk about loneliness, and then I'm going to finish off with anxiety. So the beginning, I want to talk a little about schizophrenia and the heart. So a lot of my work looks at interoception and different systems in the body, and I have a particular focus on the heart. And in this study, in nearly 400 patients, we look at heart rate and heart rate variability. So heart rate is just how fast your heart is beating, and variability is how regular those heartbeats are. And actually, it's adaptive to have a heart which doesn't beat regularly. You want your heart to be flexible in the way it responds. And we can see when we look just at heart rate itself in all of these different conditions, we have healthy controls in green, and then we have depression, anxiety, a mixed diagnosis of depression and anxiety, bipolar, emotionally unstable personality disorder, schizoaffective disorder, and schizophrenia. You can see that the heart rate is lowest in control individuals. And in all of these different patient groups, you have an elevated heart rate at rest, and it's most strikingly high in those individuals with schizophrenia at rest. And then in terms of heart rate variability, again, it's adaptive to have this variable beating heart, and healthy controls have the greatest heart rate variability. And then you can see this monotonic decline in the variability of the heart, with it being lowest in individuals with schizophrenia. And these data are also potentially informative for the onset of the condition. Although this work is cross-sectional, there's work from longitudinal samples. For example, one of the big Scandinavian cohorts, which was looked at in healthy young men aged 17 and 18 who were being screened to join the army. At this point, they didn't have any symptoms of schizophrenia, but it was found that those individuals with a high resting heart rate, specifically above 80, were over 20% more likely to subsequently develop schizophrenia. So there seems something informative about the heart that is observed and seen prior to the onset of schizophrenia. And I think this work is very new, and we're starting to build a picture of cardiac abnormalities in schizophrenia. So this was from 4 years ago, and it was a study which showed cardiac abnormalities in terms of structure and function of individuals who were schizophrenic. However, most of these individuals were on medication, and it was hard to disentangle what was the effect of medication on these different cardiac parameters, but it is definitely showing an association of schizophrenia with cardiac morphology. And then in this study that came out this year in Lancet Psychiatry, it took a very clever approach to look at potentially the shared etiology of schizophrenia and cardiac abnormalities by looking at genetic liability for schizophrenia, looking at the UK Biobank data and showing that individuals who are just more genetically likely to get schizophrenia or presence of schizophrenia in the family were associated with a number of different cardiac morphology changes. Cardiac volume was decreased, changes in the ejection fraction, and changes in diastolic presentation. And we know that individuals with schizophrenia are much, much more likely in later life to suffer cardiac arrests and have cardiac problems. And this is suggesting that there is this sort of shared and makeup in the genetics of schizophrenia and propensity for these cardiac abnormalities. And one of the reasons I think this is deeply informative is that actually I wonder, and there's emerging evidence to suggest that actually could we target schizophrenia through different medications that act on the cardiovascular system. And this work is so preliminary, and there is early evidence to suggest that using drugs such as statins, which are commonly given drugs for cardiovascular changes such as high blood pressure, can actually protect people from schizophrenic episodes, and also protect people from bipolar episodes as well. And this was work done actually at UCL, where they looked at medical records of people in Sweden, and they just analysed a number of different parameters and different drugs that people were taking. And they found that for severe mental illnesses such as schizophrenia and bipolar, they happened to observe that in individuals who were taking medications such as statins for cardiovascular function, they saw a 10 to 20% drop in different schizophrenic episodes and bipolar episodes. So understanding the shared morphology and etiology of things such as cardiovascular risk and schizophrenia then open the door for targets and treatments that may act through bodily systems such as the cardiovascular system. Next, so it's really going to be a talk in 3 parts. So next, I want to look just as another sort of case study example to examine loneliness, which is another area that I'm doing some research. Loneliness is most often defined as a subjective negative feeling resulting from a discrepancy between desired and achieved levels of social contact. So it's actually assessed through asking people, how lonely do you feel? It's very much a subjectively reported thing. And we were doing work looking at levels of loneliness in autistic and non-autistic individuals. And actually, this was the only data that's made me cry. It was just the most heartbreaking data to work with. we found strikingly high levels of loneliness in the autistic population, which was comprised of, it was adults, but a lot of them were sort of young adults, and levels were incredibly high and much higher than the comparison subjects. But because loneliness, maybe we wondered, could it be that individuals who are autistic interpret loneliness in a different way? Maybe it's something that they actually might seek or want, because that's what some of the negative stereotypes say. We didn't think this was the case, but to counteract the argument, we explicitly also asked people, and how distressed do you feel about the loneliness you experience? And we found that actually autistic individuals experience far more loneliness distress than non-autistic matched individuals. So it's not that they seek this solitude, it's profoundly distressing to them as well. And here you can see a tight correlation between both loneliness and loneliness distress in both groups. And we found that when we're looking at severity of autism with loneliness distress, we find that the more autistic traits that the comparison non-autistic group had, the more loneliness distress they reported. And we didn't find a correlation between autism severity and loneliness distress in our autistic sample. And then when looking at the mental health of this sample, we were able to observe very, very high levels of depression in our autistic sample relative to our comparison group. And actually these levels of depression also correlated with both loneliness and loneliness distress as well. So here, supporting the evidence, which is known that loneliness is associated with heightened mental health conditions, and extending this to an autistic sample. And there's been lots and lots of work that's looked at how entwined loneliness is with depression and anxiety. It seems to be most tightly linked to depression, although associations with anxiety exist as well. And there's this big review, which is excellent at looking at the literature, and it looks at both cross-sectional work, like this work that I've just presented, but it also looks at a few longitudinal studies as well to demonstrate that loneliness is causally related to the development of depression, with evidence suggesting anxiety as well. It's also demonstrated in this systematic review that it's the duration of loneliness, which is the greater predictor over the intensity of loneliness. And it also shows causal and longitudinal evidence of increases in loneliness, depression, and anxiety after COVID-19 isolation. And there's also a lot of work, particularly in adults, demonstrating the association of loneliness on different physical conditions, with a growing body of work extending this into adolescents and young adults. So in this large sample study, where they looked at adolescents and young people aged between 16 and 29 with a mean age of 22 years in over 19,000 individuals, they were able to show that loneliness was associated with significantly greater incidences of asthma, diabetes, migraine, osteoarthritis, rheumatoid arthritis, hypertension, slip disc, back pain, and tinnitus. And then when controlling for a number of socio-demographic variables, diabetes was the only one that wasn't held when controlling for those socio-demographic variables. The rest held. But because this work was cross-sectional, the authors themselves acknowledged that they can't talk causally about this. Again, loneliness could derive or loneliness can lead to changes in health behaviors, psychological factors such as stress, disruptions in restorative processes, disruptions in sleep, and other instances which can lead to changes in physical conditions, or poor mental and physical health could lead to increased loneliness. And while these pathways and mechanisms are being mapped out to a greater extent in older individuals, there needs to be a focused work in younger people to fully elucidate these mechanisms and pathways and directions. So next, I'm going to move on to anxiety. So anxiety is associated with changes in cardiovascular signals. And anxiety is also associated with altered processing of these cardiac signals. So, for example, people who are anxious do a lot of self-monitoring and have an increased self-focus. And depression and anxiety, and I do a lot of this work where I ask people how aware they are of the body and how aware they are of bodily changes. And people with depression and anxiety are very, very aware, or report being very, very aware of what their body's doing. There seems to be this shift in sort of interoceptive and self-focus relative to focus on the external world. And my work also looks at the precision and accuracy with which individuals can detect bodily sensations, because the ability to detect internal bodily sensations precisely also gives people an ability to regulate what their body's doing. And interestingly, being aware of the body doesn't necessarily equate to being accurate about what the body's doing. And actually, a lot of my work shows that individuals with anxiety report being very aware of the body, but actually have reduced precision into what the body's actually doing if we monitor them in the lab. And this speaks to a potential reduced capacity for them to regulate if they're lacking this precision into what the body's doing. So just in this shortened talk, I'm going to jump to the end of a large-scale clinical trial that we did in autistic anxious individuals, where we taught them to be more precise about when their heart was beating. So they might have been very confident and report being very aware of their heartbeat, but when we took them to the lab, they actually weren't precise and didn't have good ability to accurately detect what their heart was doing. So we trained autistic individuals through sort of biofeedback techniques, via exercise and different types of feedback to be more accurate with what the heart was doing. This we called aligning dimensions of interoceptive experience in our autistic group. That's represented in red. And the D prime is their capacity to detect when tones were in sync or out of sync with their heart. It's a very hard task. It's an internal-external integration task. The tones are always presented at the same frequency, irrespective of whether they're in sync or out of sync with the tones. So people really need an accurate pathway to detect their heart and then integrate it with when a tone's being presented. And following interoceptive cardiac training, we were able to make our interoceptive training group more accurate at this task. And we were also then able to observe a drop in anxiety in this interoceptive training group in red. This is published at the moment in eClinical Medicine, but we've now also unblinded the 1-year follow-up data, which shows that these drops in anxiety were maintained after 1 year, which I was thrilled about. And what we could see from this data is that the drops in anxiety at the group level were modest, but actually this reflects the fact that some individuals responded better to this treatment than other individuals. So we pre-registered a threshold ahead of time about what we defined as recovered. Of course, recovery is not just a number, it's many things, but we had a clinically meaningful assessment of recovery, which was a 6-point drop on a 20-point scale, which was clinically meaningful, and a score below 55. And in our active interoceptive training group, we found that approximately a third of individuals met this criteria for recovery, relative to our control group, who also underwent an active intervention. So it does seem that this sort of focus on the body and training people to be more precise of what their body's doing may help approximately a third of anxious individuals. We also scanned brains before and after to look at changes in functional connectivity. Insula is a region which is very much related to the neural sensing of bodily sensations such as the heartbeat. And we found enhanced right insular connectivity following this interoceptive training with this area in the ventral medial prefrontal cortex. The MPFC is a control region. So I like to speculate that this is linking this insular region involved in the sensing of bodily sensations with this control region. And we also observed greater connectivity between the left insula and this ACC region. The ACC is a really interesting area because there's lots of debate in the literature about what it does. But actually, if you look at arousal signal in the body and regress it within neuroimaging analyses, then actually it's the ACC that pops up. And it's also an area in the brain that represents autonomic arousal. So this data to me also suggests that greater precision with sensing when your heart is beating also leads to greater coherence in the brain of bodily arousal signals. And these were autistic individuals that we taught to be more interoceptively accurate, but we've also replicated this finding in a non-autistic group, showing that this enhanced interoceptive precision actually is effective for non-autistic individuals. But I just want to read you some of the reports that some of the autistic individuals experienced following this interoceptive training, because I also think they're informative. So one individual, interestingly, discussed a reduction in sensory overload following this interoceptive training to the heart. They said, as the inner channel gets clearer, the outer channel gets more quiet. And a lot of these individuals who are autistic experienced sensory overload from senses in the outside environment, such as vision and audition. And they had sort of a lack of clarity with the internal interoceptive channel. And it seems that strengthening this internal channel actually served to decrease the intensity of the outside world. And I think very much about internal and external processing being a bit like a seesaw. You sort of oscillate between the two. And if you're able to make the internal channel more defined, then it seems to, based on this person, and studies need to support it, to see whether we can also dull the external processing through this enhanced internal precision. Another individual spoke to an increased capacity for regulation that came with this enhanced precision to the heart. They said, when I notice the impacts of anxiety on my body, I'm more aware of them, and I'm able to reassure myself that it's just a physical reaction. I'm better at taking deep breaths and trying to slow my breathing and heart rate down rather than letting it spiral. And I think this speaks to early access into bodily changes, give people the capacity to then regulate them at an earlier point. It's easier to regulate by taking deep breaths when your anxiety is just starting to ramp up. And you notice that early rather than suddenly becoming aware that you're anxious when you're already in a meltdown or a panic attack. And then someone else said, I believe it's increased my awareness of hunger, and as a result, I remember to eat, drink, and go to the toilet. So this suggests that enhancing accuracy to one bodily system, the heart, may also generalize to other bodily systems, allowing people to better regulate when they eat, how they eat, and other processes. So much of my work and the work of other people is interested in looking at these different interoceptive bodily systems in the body. I've talked a lot about the heart, but actually there's all of these different bodily systems. And these bodily systems can underlie changes in physical health, but I believe there's growing evidence that they also can underscore changes in mental health as well. And different drugs that target the body may also have changes in mental health symptoms as well. And as we go forward in the future, different therapies that change bodily systems, such as mindfulness, which can change respiration patterns, and different drugs, such as propranolol, that act on the body, may have these implications for treating mental health. And there may be drugs which may act to help both physical and mental health conditions, with the possibility of a shared etiology underlying both. So to conclude, the brain and the body are intrinsically and dynamically coupled. Physical and mental conditions are highly associated, and novel treatments which target the body may help physical and mental conditions through targeting shared etiologies. So thank you to the funding agencies and collaborators and lab, and thank you all for listening.
Thank you so much, Sarah. That was absolutely fantastic. Just so exciting, and it just sort of intuitively makes just so much sense to be able to tackle things in this way. So thank you very much. And we've got a comment in the chat saying, fantastic talk, strong case for moving forward towards symptoms rather than sort of a physical or mental health sort of dichotomy in that way. So many, many thanks. And you're exactly 25 minutes. So on the nose there. Thank you, Sarah. And you'll stay around and we'll have some questions at the end as well, if that's okay for you. Great. And now it's my pleasure to move on to introducing Dr. Sophie Bennett, who has many hats, but I've been working very closely with Sophie over the last 10 or so years. Sophie's an assistant professor at the UCL Institute of Child Health, but also a senior clinical lecturer at King's. And the work that Sophie is going to present is very dear to my heart, and is talking again about mental health, physical health sort of interface, but coming at it specifically with regard to mental health treatment for children and young people with epilepsy. So over to you, Sophie.
Thank you. It's not just the epilepsy study, but I will tell you more. Can you see this okay?
Yes, it's here now.
Perfect, thank you. So thank you, Roz. I'm going to be talking about approaches to treating mental health disorders in the context of chronic physical illness. And as Roz says, I've been working with Roz for a few years now in the psychological medicine research team that's led by Roz and also Professor Isabel Heyman, who's just had to drop off the call. We do lots of different studies related to the integration of mental and physical health in children and young people. But today I'm going to be focusing on two of the biggest studies that we've got ongoing in the group. The first one is the study on children with epilepsy, so the mental health intervention for children with epilepsy study. And then I'm going to move on to what we call the Lucy project, which the name will become clearer when I get to that part. And then finally to think about the next steps for our research and for clinical work in this area in general. So to start with the mental health intervention for children with epilepsy, otherwise known as the MICE study, and associated with this MICE logo that one of our team was very creative and designed for us. So why children with epilepsy particularly? Well, we know that children and young people and adults with chronic physical health conditions are more likely to have mental health difficulties, as Sarah's already talked about. But children and young people who have neurological conditions like epilepsy have much higher rates than children who don't have a chronic physical illness. So in this study, which is one of many, it's suggesting that children with epilepsy are up to 7 times more likely to have a mental health disorder than children without. And that has been known for many decades now. The problem is, despite us knowing that epilepsy is associated with significantly higher rates of mental health problems, those mental health problems are not really getting recognised, they're not getting diagnosed. When they are getting picked up, they're not getting treated. Lots of reasons why that might be. Potentially people understandably are focused on the physical aspects of epilepsy, so things like the seizures. Maybe people don't understand that it is possible to treat mental health conditions in the context of a chronic physical illness. But one of the potentially biggest reasons, and one of the areas of focus for our research group, is that physical and mental health care is typically separated. So this is a figure that comes from the Epilepsy 12 audit, national audit of epilepsy services in England. And this was a couple of years ago, but the figures have not changed very much since then. It shows that only 12.8% of epilepsy clinics were able to facilitate integrated mental health care provision, so had mental health care provision from within their epilepsy service. So what happens typically is that if the difficulties are identified, and there might be problems with that given that many of the people in epilepsy services are not trained in mental health and identifying mental health problems, if those difficulties are picked up, people are typically referred to child and adolescent mental health services. This is a study that was led by Georgia, who is our MSc student, just looking at what might happen to those young people when they do get referred to CAMS. So she had vignettes of a referral for Jenny, and Jenny in this referral either had anxiety or she had the exact same referral word for word, except the referral also stated with nothing else that Jenny also had epilepsy. And then there was another condition where the referral stated that Jenny had anxiety, but also autism. And what you can see is that clinicians were far less likely to say that they would accept the referral if there was a co-occurring condition like epilepsy or autism than anxiety alone, despite that referral in all other respects being exactly the same. So what's happening is these children and young people are potentially getting turned away from mental health services. So then where does that leave them? This is a video from an Oxford team and their health talk videos. And I think this illustrates nicely what is happening to children and young people who have mental health problems in the context of epilepsy. It does take a few seconds to start.
It's just stress, really. Like, I mean, I've had a couple of stressful patches over the last year, and like stressful patches relationship-wise, when I stopped eating, and really didn't look after myself very well. But the stress can make you feel very anxious, and it's not nice. Because you just feel on edge all the time, and you feel like, oh, am I going to have a seizure? I don't want to go out because I might have a fit, like on the street. There's been times when I've been walking in like department stores looking at clothes, and it's just all got too much for me. And I started feeling strange, and I just had to get out. But I really need to start sort of not thinking about it as much, because even now I still think about it a lot. Like a few times a day. But I need to start to forget about it. I might go and see my, we have an epilepsy nurse at the hospital, which I go to. Yeah. And he's really lovely, he's a really nice bloke. And if I do have any problems, I can always ring him or go and see him. I'll go and have a chat with him soon. Yeah. Book myself an appointment, I'll go and have a chat with him about the anxiety.
So what you can see is that actually children, young people and their parents typically are reporting that they turn to their physical healthcare team to discuss these difficulties. And oftentimes that's with their epilepsy nurse, who they have, I guess, the strongest relationship with. So epilepsy nurses are being left to manage these mental health difficulties, despite having no specific training in evidence-based treatment for common mental health difficulties, which is where mice comes in. So in the mice trial, we trained people from within epilepsy services. So that included epilepsy nurses. We also had some paediatricians, neurologists, as well as research assistants, assistant psychologists, to deliver an evidence-based cognitive behaviour therapy intervention, which we named MICE, Mental Health Intervention for Children with Epilepsy. And that's based on this modular protocol, MATCH ADTC, which is the modular approach to therapy for children with anxiety, depression, trauma, or conduct problems. So what a modular protocol basically means is that it has these different modules for different mental health problems, and within those modules it also has different practices or sessions, and together those modules can be combined in different ways, which means that you can really personalize the intervention for each different young person that's coming through, and it's particularly important in the context of epilepsy, because we know that many, if not most, children with a mental health difficulty in the context of epilepsy will actually have more than one mental health difficulty. So this allows us to address more than one mental health difficulty within the same protocol. It also allowed us to add a module on. So rather than starting from an intervention from scratch, we added a module on about the relationship between epilepsy and mental health, named the ESME module. So the programme of research itself, in our first work package, we developed that epilepsy-specific module, and we piloted that intervention using plan, do, study, act cycles, which is a quality improvement methodology. I don't have a lot of time to go into how we developed that, but in brief, it was with lots of feedback from and discussion with clinicians, stakeholders, most importantly, parents and young people themselves, and you can find more information in this paper. In our second work package, we then trained services and piloted the fully developed intervention. And again, I don't have time to go into that part of the study, the programme in depth, but both the qualitative and the quantitative aspects have been published. Needless to say that the intervention was really well received by both the clinicians and by the young people and their families, which allowed us to move on to the next phase of the programme. One of the other main outputs that came out of that training and piloting the intervention was also our therapist platform. So the point of the MICE study was really to address a need, an existing need within services. So throughout the programme, we wanted implementation to be a strong focus, for this to be able to be used going forward and not just in the research trial. So we recorded all of the therapist training, and it was accessible online, which was really important during COVID, but also going forward, if any new therapists need to be trained, people don't have to come down to London to receive that training. Everything's on this platform online. So the main part of the programme, which I am going to talk about, is the randomised control trial of 334 children and young people. And there's also an associated qualitative outcome and process evaluation. So the trial itself was looking at the mice intervention, and in comparison to assessment enhanced usual care. So we called it assessment enhanced because everybody had a mental health diagnostic assessment, and the development and wellbeing assessment, which was completed online by families before being included in the trial. And the results of that were shared with all clinicians as well as the family, and that is different to usual practice. You might be able to see in this image, typically what assessment enhanced usual care consisted of was, again, referral to external services if people were referred, and then they often went on long waiting lists. In terms of the finer details, for those interested, we took 330, well, we planned for 334 children and young people. You can see that the age range and inclusion criteria, so we included young people with intellectual disability and young people with autism, was broad, and that was on purpose because we really wanted the participants to represent who was coming into clinic. Again, we wanted this implementation focus. We wanted to address the needs of the population rather than coming up with arbitrary inclusion-exclusion criteria to make it easier to write the study up. So we had this wide inclusion criteria, and people also had to be able to attending epilepsy clinics and have a mental health disorder according to that diagnostic assessment. In terms of outcomes, the primary outcome was the Strengths and Difficulties questionnaire, which many of you will be familiar with, but is a commonly used measure of mental health in children and young people's mental health services. And we had secondary outcomes looking at quality of life and the mental health of the child and the parent. QR code has all the details of the paper. We do have a health economic analysis, but again, for time, I'm not going to have time to present that today, and that's currently underway. Again, we wanted the study to be representative of children coming into epilepsy clinics across the country. So we had main sites across different types of hospital site in London, but we also had patient identification centres where patients could be referred from these sites across the country. So it's several across England and also one in Northern Ireland. You're not going to be able to read this consort diagram, but safe to say we recruited our 334 children and young people pretty easily. And we had an extension due to COVID, but then we were ahead of our recruitment target, a revised recruitment target from COVID. Overall, we randomised about 24% of those who were approached, and we had a really high follow-up rate. So 89% of children and young people who were randomised then completed the follow-up measures at 6 and 12 months. In terms of who those participants were, about 25% of them had an existing autism spectrum disorder diagnosis. About 40% had an existing intellectual disability diagnosis, and about 65% reported having had a seizure in the past 3 months. And again, that's important because this is not a group of children and young people who have well-controlled epilepsy. They are still having seizures. About half had disruptive behaviour as their main mental health difficulty, 40% anxiety and 5% depression, but bearing in mind many of them had more than one of these difficulties. The therapy itself, 164 of the 166 had at least one therapy session, and an average number of 16. That might look high, but bearing in mind that children might have more than one mental health disorder, so we're treating more than one mental health disorder in the protocol. But also we know that it might take longer when a child is autistic or has an intellectual disability. 21 therapists provided therapy sessions, so that included our assistants, but also the epilepsy nurses and the paediatricians. And this is the bit where we need to stop the recording because this is not published yet, but to talk to you about a second study. So the MY study looked at integrating mental health and physical health care through training clinicians in the physical healthcare setting to deliver evidence-based intervention. This is another model which is a drop-in mental health centre. So it looks at providing early access and self-referral options for mental health treatment in the context of a paediatric hospital. So we had this booth, aptly named the Lucy booth, in the reception of Great Ormond Street Hospital. Isabel has gone, but I think the name of the Lucy booth came from Isabel's idea from the Peanuts cartoon, where Lucy sits in her booth and provides psychiatric support. So the aim of our drop-in study was to evaluate the usefulness of that drop-in in Great Ormond Street. And it provided evidence-based interventions and support in relation to emotional and behavioural difficulties. This time, not just for the children, but also for their siblings and parents at the hospital. The aim was to integrate that with existing services and not to duplicate involvement. So at Great Ormond Street particularly, there are lots of paediatric psychologists. And so if somebody came into the booth, we might refer on to those paediatric psychologists and so act as a single point of access. And we really focused on providing early intervention and using low intensity intervention. So things like guided self-help as part of a stepped care model. And the research questions were to look at the impact of this transdiagnostic mental health centre on, similarly to mice, on emotional behavioural symptoms, on quality of life, and on the acceptability of the service. So in terms of the results, again, I'm not going to have time to go into these in great depth, but all of the QR codes linked to the papers that we've published on this. And the initial study undertaken at Great Ormond Street Hospital was part of Matteo Catanzano's PhD. I think Matteo might be here, so might be able to answer any questions that people have about it. But overall, the results were that the SDQ was just statistically significant difference between baseline and follow-up on the SDQ for the total score and for some of the subscales. Similarly for the quality of life measure. But again, perhaps most importantly, it was also feasible within that hospital setting and acceptable to the families who received that intervention through the Lucy booth. Not only that, but we've also now published on the effects for parents and for siblings, and there were similarly positive outcomes for both parents and siblings attending that drop-in mental health centre. So moving on finally to our next steps for our research. So the Lucy booth was successful, and as a result, Anna Roach is now completing her PhD on a national rollout and implementation of that drop-in centre model. So we've got sites all across the country, and it's really exciting that actually some of those sites have now got funding to continue with that model following our implementation study. Anna's implementation study. So that model has really been taken up as a way to increase access to mental health care within paediatric hospitals. And similarly in mice, so you can see the headline, increased access from 17 years to 17 days. You may have seen the papers, the stats, that it on average takes 17 years for a study to go from the research into clinical practice. And I don't think 17 days is an exaggeration to what happened in mice. Actually, sites were so excited by the study and the outcomes that they were seeing for their families that word got out, and word got out to NHS England before the results of the study were published. And NHS England have commissioned pilot sites across England to deliver the mice intervention. And I think that goes to show that focusing on implementation at the beginning has really supported us to make sure that these types of interventions are available to children and young people who need it the most. To acknowledge all of our team and the funders. And then I think we are up for question time. Thank you.
Thank you so much, Sophie. That's a whistle-stop tour through the last number of years on this work, but again, just really showing a very different kind of interface between physical and mental health from Sarah's, but so complementary. It's very exciting. So we can open it up to questions. We've got 3 questions already from Irene, and you can either post them in the chat or raise your hand, whichever you would like. But Sarah, are you ready? What is the mechanism linking low HRV and schizophrenia? For example, does unusual threat processing or poor emotion regulation increase the risk of both? 3, does the link between low HRV and schizophrenia attenuate after controlling for executive functioning?
These are great questions, and I really don't think we know yet. I think were it just the initial data that I presented, then it could be down to your point 2, which is a different way of regulating emotion, increased threat processing. Like, it could conceivably be one of those. But I think with the UK Biobank work and the work which shows giving statins, which changes cardiovascular function, can actually be protective against schizophrenic episodes, I think it speaks to something more deeply profound about a shared, and this is going to sound really radical, but a shared etiology of schizophrenia and cardiovascular function. So schizophrenia has been thought of typically as a brain disorder. And I want to be radical and say, is it a disorder of the body, cardiovascular systems that contribute to the manifestation of schizophrenia? We don't know yet why or how, but given causally statins decrease schizophrenic episodes, there's something very, very exciting in that direction. And it's my hope, actually, that we move away from schizophrenia as a brain disorder and start to think about trialing drugs and understanding more these pathways between cardiovascular interactions and the onset of schizophrenia.
Thank you. Irene, did you want to comment back?
No. I was very intrigued by the findings. I'm very interested in heart rate variability in children, actually. So not exactly your population. And I really think there is something there. I have some preliminary data from various cohorts across Europe. I think there is something there, but perhaps childhood is not the right sort of time to look at linkages with sort of unusual patterns of outcomes. But I was intrigued. I was really intrigued by your talk. Thank you very much, Sarah.
Thank you. Any other questions? Sarah, perhaps I could ask one that maybe trying to interface between you and Sophie, your work together. So I think if we take a kind of CBT approach and you have the thoughts, feelings and behavior, and I know as my daughters are doing A-level psychology, that's sort of oversimplified as people thinking that means that thoughts lead to the feelings that lead to the behavior, but actually it's an interactive system. And I just wondered about sort of, if you take that kind of approach to your work, you're really suggesting intervening at the kind of physiological level. So I guess I wonder about in my mind, I'm trying to link your work with David Barlow's work on interoception for panic disorder, and then sort of briefer interventions, such as the ones that Sophie described. And, you know, if you had to start somewhere, if we only had a brief intervention, where would you start and why? I'll ask you, Sarah, first, give Sophie some time to think.
So I think emotional disturbance and distressing emotions seem to be fundamental to so many different mental health conditions. And I think the research is converging to suggest 3 different interoceptive facets or profiles are important. 1, we need precise access into these signals because that helps with regulation. 2, we need to not worry about the signals in our body. And 3, we need to not over attend to these signals. We need to be mostly focused on the world. And I think teaching people to have precise access to these signals, regulate them, not worry about them, but also not be preoccupied with them, is actually something we can do very, very early on and simply, and it seems to change brain connectivity. So I think greater emphasis on that could be easily done, and it has wide-reaching implications for general emotion regulation, and also it helps change the sort of characterization that you see where people become overly monitoring of body, which is not good either. And these are things that can easily shift and have implications for many different conditions.
Thank you. So Sophie, I don't know how you think that might be integrated into a brief treatment. If you've got any comments, thoughts?
That's a different question.
Well, whichever question you want to answer. Then
I was going for what brief treatment. I mean, I think there are people looking at interoceptive work as a brief treatment in children and young people too, aren't there? But I know you know already, Ros, but I guess in terms of low intensity interventions, the evidence from Matteo's done a systematic review, and I guess all the reviews and the work that we've done so far suggests that we know children benefit from low intensity interventions like guided self-help, and there's no reason that children and young people who have a chronic illness shouldn't benefit similarly to those interventions. So I think a starting point is making sure that we're using evidence-based interventions and working from there rather than necessarily starting from scratch without evaluating the existing evidence-based interventions.
Thank you. So and I guess that would be Sarah, sort of something around the idea that you could have a brief interoceptive intervention that would apply equally well to children and young people with chronic illnesses without.
Yeah, absolutely. I think that's right. Because it has implications also for symptom perception. I think people with chronic illnesses worry a lot about what their body's doing, and rightly so. There is things profoundly going on. But if we can help teach them with precision of what the body's doing, then that also can maybe help them with over monitoring of the body as well, as those pathways are better. Like, there's really fascinating data to suggest that if you teach people greater touch acuity on the skin, then it helps them manage pain better. So there's something about the precision of which you sense bodily signals actually helps alleviate symptoms, because it's something about that precise processing which seems to be helpful for general physical as well as mental symptoms.
Thank you. And a question in the chat. Thank you for the great talks. And Sarah, this is a question for you. Could you elaborate on ACC activity and cardiovascular activity?
I'm obsessed with this question. This is such a nuanced point which neuroimagers really, really argue about. So there's been this argument in the literature about what the ACC does, and people have really had fights. Like, some people say it's about conflict, other people say it's about other things, and there was this sort of this historic war about what the anterior cingulate activity is doing. However, if you take a measure of bodily arousal, such as changes in heart rate or changes in skin conductance, and in a model-free way, you regress this physiological change within an fMRI model, then out pops the ACC. So what it's saying is that the ACC activity is actually linked to autonomic arousal. A higher autonomic arousal, higher ACC. So I think all these battles about what the ACC is doing, it's not picking up on that cognitive function, it's picking up on the arousal that cognitive function elicits. So it's actually this sort of so-called proxy for emotion signature, if you want to equate emotion with arousal, but this is arousal signature. And I love seeing fMRI maps which actually come out with this arousal map, because it's actually just tapping into that arousal signal.
Thank you very much. It's lovely to see your excitement at the question too. That's great. Other equally exciting questions from anybody? Don't have to be that exciting if you'd not. No? Well, maybe we can give everybody just a few minutes back of their time, and a massive thank you, because it's such an important area, and you're both coming at it from such different ways, but converging on the importance of working together, integrating, and benefiting children and young people's mental health. So thank you on behalf of the Catalyst Seminar Group, and thank you everybody for giving up your time and coming. Thank you for those who are watching on recording, and see you at the next seminar. And Patrizia, I don't know if you want to say anything about the next seminar?
Hi, yes, we will disseminate information shortly, but it'll be again the first Wednesday of December, so it should be the 13th. And we will share the link and all the details soon to our mailing list.
Thank you very much. Thank you, everybody. Take care. Thanks, Patrizia. Thanks, Naomi. Thanks, Sarah. Thanks, Sophie.